So let's talk about seizures. Two types of primary, well, there's actually a bunch of different types of seizures. I'm just not smart enough to tell you about all of them, okay? When you get into epilepsy, there's like a gazillion forms of epilepsy, all right? And when you get into seizures, there's like a bunch of forms of seizures, okay? Are you going to do that again? There's a bunch of forms. I think I got stuff on my iPad.
I was starting this way.
It sprays everywhere. Anyway, so there's different forms of seizures. So once you sort of get into, you know, neurology in college, and you're saying, oh, you didn't mention these types of seizures, remember back to this conversation that there's more than what we're going to talk about. Neurology is not one of my favorite subjects because of the fact that it is too complicated. It makes my head hurt when I start thinking about it. And so what we're going to cover is primarily two types of seizures. Tonic, you can put out to the side here, tonic-clonic seizures. Generalized seizures are grand mal, M-A-L, not grand mal seizures. Grandma is not having a seizure, it's grand mal. Or tonic-clonic. Tonic-clonic is the jerking and relaxing motions. Tonic-clonic is probably a better definition because you can have tonic seizures, you can have clonic seizures. Tonic is in, if you're making a martini, tonic, clonic. Or generalized seizures, and this is like it says here, this is where they do the sort of the convulsing types of things. Now, there's a lot of myths about seizures that we're going to clear up. And the first myth is that you're seeing, everybody knows, you've seen at least the pictures of it, you take a fish out of the water, right? Little goldfish, throw them on the table there, and the fish is going to flop back and forth, right? Sort of flipping back and forth like that and flailing its little fins around. That's not seizures. Those are people who fake seizures. There's a lot of people who fake seizures, okay, for different reasons. Primarily, they fake them for the drugs. They get really high on the drugs that they get faking seizures. And then there's a lot of people fake them for emotional type things. They get in some sort of domestic disputes with a spouse or a family member and they have a little seizure. Go ahead and when your report cards come out, you can fake a little seizure. Your parents will not be thinking about your grades. They'll be looking, why is she flopping on the floor like that? You know, that has happened many times. Go out to someone's house, 16-year-old having seizures. Really? No. Get up. Face your consequences. Don't fake seizures. So you have this. The tonic-clonic, when you see a seizure, it is, and you can go to YouTube. I went there yesterday and just couldn't find any good ones. But it's a drawing up or out. Remember when we talked about posturing? Okay, a lot of people who have seizures have the cortigate type posturing where they draw up and they seize, but it's a very tight type of contraction. Or they have the cerebrate posturing where they push outward and they seize, but it's still a tight contraction. What it is a seizure is, by definition, is a chaotic firing of the neurons, a disorganized firing of the neurons. The best way I can describe it to you is, y'all seen the cartoon Bugs Life? Yes. Love that cartoon. All the ants, right at the beginning, all the ants are in line. And they have their little food they're going to throw on the top of the mound for Hopper, right? Because they don't want to face Hopper. And you have that one little ant that's always trying to do something a little different, remember? Flick, that's right. And Flick knocks something over. No, a leaf comes down. That's right. A leaf falls. and it falls in the line of the ants, and what happens to the ants?
Lost.
They just start going everywhere because this leaf. And that's what happens within a seizure is that for some reason, and a lot of the reasons are unknown, the neurons start to fire at a disorganized rate and causes contraction and relax, contract, relax, contract, okay? All over the body at once. Now, we remember in Bug's Life, the guy, the ant with the little white hat, he's like, it's okay. It's okay. Calm down. We'll go around the leaf. So everybody sort of gets back in line, right? And goes around the leaf, and then everything's back to normal. Until Flick knocks the whole pile over. So, that's sort of what happens in a seizure is, you get this disorganized firing of the neurons. They all fire differently. We fire at a certain rate. All the neurons in the body fires at a certain rate. And I knew that rate at one point in time. I want to say 60 hertz, but that's electricity. So it's in hertz, the way that they fire. I just don't know the number. And the number is not really that important. What's important to remember is they all fire in sync. And they fire at a certain rate. And what happens is when this rate gets distorted, they start misfiring. Just like a car, if you took out one of the spark plugs, it would start to misfire, right? And shake and stall and do all that. Until the brain can get all this back in sequence, and then the seizure will stop. Now, once the seizure stops, there's this time, it's called post-ictal. It's a weird word. I don't know where it came from. Post-I-T-C-A-L, I think is the way it's spelled. Post-ictal state, or you can just put a recovery state for now. They're post-ictal, not postal, but post-ictal. So they get in this post-ictal state, or this state of recovery. Because when someone's having a tonic-clonic seizure, they're not doing a couple of things. All right? One thing that they're probably not doing is breathing very well. That's why they get real cyanotic and pale and flushed during the seizure. If they're breathing at all, they're not breathing very well. So they need a state of recovery, sort of to recover everything, get all the neurons back together, okay, and get back in line. So the post-ictal state is a state of recovery. And this state can last anywhere between 5 minutes, 2 minutes, to 20 minutes. I've had patients who were post-ictal for over 20 minutes. They were the whole route. They couldn't speak to me. They weren't seizing anymore. They were just sort of gazing off to the side and blinking. And I'd ask them if they were okay, and all they could do is shake their head. And they were post-ictal. So I gave them an oxygen by non-rebreather at what liter?
Oxygen non-rebreather.
10-15 liters per minute, right? Which give them what percentage of oxygen? 90 to 95, right. So you get a high concentration of supplemental oxygen to their brain because that's what they're lacking. You know, they're lacking that oxygen because they haven't been breathing very long or during the seizure. Now, that will also tell you about the time frame on the seizure. Is most seizures only last between 1 and about 3 minutes. They're not very long. If someone's having a very long seizure, then it could be life-threatening, or they're faking. A tonic-clonic seizure. Okay? Now, these only last usually a couple minutes. The patient has no recollection of the seizure. They know that they seized because they get this euphoria, this sort of, there's another word for it, I can't remember. Anyway, they get this sense that they're going to seize. What is that word? Oh, but no, a sense that they're going to seize. They feel like, oh, here comes the seizure, it's coming on.
The sixth sense?
No, there's a word for it, I forget. Anyway, we'll get back to it. So most everybody that will seize that has a history of seizures, they get this feeling that it's about to happen. So they prepare themselves. So like me, if I was going to say, oh, I'm going to have a seizure, I would lay down this pad, right? All right, because I knew I was going to seize. So they don't really have a recollection of how long the seizure lasts. They just know that they probably seized, okay? One, because they're usually in this postictal state or after the seizure, they're very pale and diaphoretic. So when you walk up to them, getting that general first impression, right? So you walk up and go, whoo, something happened because you're sweating like a pig that don't sweat. And you're very pale. So two things are abnormal. You're diaphoretic and you're pale. The other thing that takes place during atonic-clonic seizures, incontinence, usually bladder incontinence, meaning that they urinate on themselves. So you're getting your good general impression, and you see the wet spot, they're pale, they're diaphoretic, and they're very altered in their level of consciousness. Now they may be able to talk to you and answer your questions, but they're very slow. So you can see through here this postictal state, this recovery state. They're trying to recover from this. So you need to give them some oxygen so that help them out and limit the questions until they sort of get their thought process back together. Right? And then you rely on witnesses, typically about the seizures. Okay? Now, a couple of things they can't do during the seizure is, one, they can't speak or follow verbal commands during a tonic-clonic seizure. During the typical grand mal seizure, they can't follow commands or speak. That's how you know that they're faking. One of the things is what I do a lot of times, and I've seen enough seizures now where I know pretty quick whether they're faking unless they're just really good at it. Some people, druggies that want the Valium or the benzodiazepine that sort of they give to the seizures will do a lot to get that high. I think it's a little bit too much, but they will do a lot to get it. So they will go up and they will be seizing, and they may be good at what they're doing. If they're just flopping all over the floor and like a fish out of water, I just simply tell them to stop. Stop what you're doing, because you are not seizing. People do not seize like that. Okay, so the cool thing about it is because they want their eyes closed. You know, they're like, you know, doing a little jig on the floor. Okay, and what I'll do to try to do this, I'll come up to them and I'll say, "Are you seizing?" And just raise my voice just a little bit. So what does that do?
Oh my God.
Yeah, exactly. If you have your eyes closed and you're trying to fake something, and I come up and say, "Are you seizing?" they're going to pause a little bit, especially if you get close to their ear. Okay? And they're just going to pause. Boom. Game over. You just follow the command. Okay? Now the newbies, okay, will open their eyes and say, "Yes." I'm like, wow, you need to watch YouTube, okay?
Somebody has said that before. They said yes.
Right?
Okay.
So they will. So as the progression goes, and don't misunderstand me, it's a quick thing, and if I really think that they're seizing, then I still sort of go through this because I want to check and see if they can follow commands, or ask the bystanders or their family perhaps. Is it a type seizure where they speak to you, you know, during this? Because there's so many different type seizures. But the generalized seizure, they can't speak to you or follow commands. Some of them are specialized where they look like they might be having a tonic-clonic seizure, but they can sort of speak to you or look or respond, okay? So don't get don't get caught short there. The other thing is I do is try to get them to follow some sort of command. So they're good, you know. I mean, they didn't pause. They're still seizing away. So we get them on the cot, take them out to the ambulance, and I'm saying, okay, I'm gonna start an IV, and they're sitting there doing this, and I pull out this arm here, and they're doing this, and I sort of, you know, make mention of I have a needle in my hand, right? And they're sitting here doing this, and all of a sudden they're doing because they're stopped the arm that I have in their hand because they don't want me to try to bounce that needle in their vein, right? I mean,
That's some pros.
yeah, I mean, they're like that. Now you have the third class. I mean, these guys urinate on themselves, they do everything, but you can't sort of fake the diaphoresis and pelvis. Very hard to do. But the other class will, they'll go all the way. I mean, they're little seeds with their hands, like, oh yeah, these guys are used to hitting moving targets, right? And I'll flush the saline, turn on the saline, and then I'll take a syringe and I'll flush the IV with the syringe. And I don't know if you ever had an IV or something there, but you can feel that going in your veins. And they think that I just gave them the Valium and they'll stop seizing. But I just pushed saline in their IV to flush it. And they go, and I'm like, hey, bust that. You know? So there's several times that they do it. My favorite one, can you guess where they're at?
The favorite one.
When people fake seizures, can you guess where they're at?
McDonald's.
Where? McDonald's.
Why not?
That would be a real seizure.
You're right, though. They're at a restaurant.
Oh, trying to get out of a date or something?
Yeah, try to get out and pay for their meal.
Really?
All of them have. It's always funny though. They've all eaten their full meal. Nobody ever seizes over the appetizer. They always seize after dessert. And so you have a restaurant full of people, and you have this guy flopping on the floor, and the good ones, man, they build up some spit and sort of throw some spit around, you know. We have other people eating, and they're going, and you know the manager's sitting there going, don't look, don't look. We get him out. So we get them to the ambulance. They stop seizing. They're out of the restaurant. They know that. And if you're ANO times 4, guess what you can do? See ya. Goodbye. I don't need any treatment, so they'll get out of the ambulance and leave. We can't stop them. They're ANO times 4, but we know that they're faking because of no postictal stay. We got them to the truck. They seized all the way to the truck. Shut the doors and they stop seizing and they wake up. So, oh, I feel much better now. Oh, I bet you do. You know, but you didn't seize because you had no postictal stay. That's the way that you can tell. The ones who they get in this domestic dispute and they go from seizing to ANO4 without any postictal state at all. You know, I had one poor lady. I sort of felt. I mean, the fire department's coming out and they're saying that this is a faker, and I'm like, yeah, we're sort of familiar with her. And she's laying in the floor. She just had a fight with her husband. Go figure, right? And she's laying there, and I'm honest with people, you know. And I tell her, I said, you're not having a seizure. You didn't have a seizure. You're historically known as faking these seizures. And this is not healthy for you. This is not a healthy way to take care of your problems. And she goes, I think I'm going to have a seizure now. I'm like, well, okay, then seize. Let me see it. And she starts shaking. She goes, look, I'm having a seizure. I'm like, no, you don't.
She said, look, I'm having a
Yeah. So I'm like, no, you're not. And so I explained to her, I said, look, at least, let me tell you something. I said, at least fake it good. If you don't fake seizure, fake it good. Don't talk to us when we come out. Just sit there and shake. Okay? because you.
She's great.
And so I told her the ways, the same thing I'm telling you. You can't follow commands. You can't speak during these generalized seizures. And not everybody fakes the seizures. Most people don't. Okay? But there's quite a few that do. So there's some common myths out there with them. The biggest thing is when someone's seizing, if they have a history of seizures, it's no big deal. A seizure is not a huge event in their life. So what we'll do is, let's say I have a history of seizures, and I think, whew, get that little sense of euphoria that, oh, it's coming on, you know. And so I said, I'm going to lay down here on the mat, not to take a nap, but I feel like I'm going to seize. So I start in on my tonic-clonic seizure, okay. There's a couple of things that you don't want to do. One, you never, ever put anything in the mouth. You get all grandmas and grandpas saying, oh yeah, stick a stick in there or a spoon or something to keep them from swallowing their tongue. You can't swallow the tongue, it's attached. Okay? What happens when they get that sort of perception of this, once the patient goes in this postictal state, okay, they're unconscious, the tongue becomes flaccid and it may fall over the epiglottis, right? And we know to do a head tilt chin lift if that takes place. Open the airway. Keep the airway open, right? So never ever anything in the mouth. Everything is just an airway obstruction. And definitely don't put your fingers in the mouth. You come up like this. They will bite your fingers off. Alright? I've had a patient one time had a seizure in the middle of an intubation. He overdosed on some drugs, and I was going to put the breathing tube in him, right? Y'all remember that big metal blade? Okay. That patient bit down on my laryngoscope blade in the middle of his seizures because they clenched their teeth and they bite down. Usually bite down on their jaw and their tongue, so you get a little blood in there, right? I had my blade in there and he seized and he bit down on my blade. I tried to get the blade out and literally picked this guy up, his torso up off the bed. It was like, let go. You know? It's like a dog hanging on to this little toy. You're shaking him and you're trying to let go. He won't let go of my blade. And he didn't bite it too. That would have been impressive. But he bit down on his blade and he wouldn't let go. So you can imagine what it would do to a finger, right?
Oh.
And never let it go.
Yeah, it's gone. Never, any unconscious person, never stick your hands in their mouth. Unconsciousness leads to hypoxia. Hypoxia leads to seizures. Okay? So be careful of that. The other thing is, don't hold the patient down. We have a tendency, because they're shaking, to hold them down. There's been several documented cases of long bone fractures because of people holding the patient down. It happened in school here one time, down the hall. Teacher was having a seizure, and another teacher was laying on top of her. I was like, what are you doing? Get off of her. You know? So never anything in their mouth. Never hold them down. Okay? Let them seize. Protect their airway. Protect them from hurting themselves. So if I was in the midst of right here, right? Then you would probably move the desk away, right?
Let them fall on the floor.
Hold my head. Keep injuring myself, right? Let me seize. Typical seizure, 2 or 3 minutes, all right? Now there's this condition called status epilepticus. Geez, what a word. Status epilepticus. You have the same type of problem. It's called status asthmaticus. These Latins kill me, okay? And status means, when you put that in front of there, that they're having one right after the other one without very little break. So the same way with an asthma attack. So if the patient could be he could be in status, so he's having one seizure after another seizure. This is life-threatening because they're not breathing, right? So we're going to grab our bag valve mask, breathe for them. Okay? And even they're clenched down, you still have the means to bag for them. Open their airway, bag them through this because they're not breathing. Later, I don't know how much later, but we will talk about different airways. One airway that you can put in, you may see it at the hospitals, and called a nasal pharyngeal airway, or a nasal trumpet, or nasal airway. Anyway, this goes in the nose, and on a seizure patient, you could use this nasal airway. You could put this in their nose, and it provides a passage between the nose and the pharynx where they can get air, right? You wouldn't be able to put an oral pharyngeal airway, or an oral airway, or an OPA, NPA, because one of those nevers. What do you never do?
Put anything in their mouth.
Put anything in their mouths, and this would include it. They just bite on it. Okay? So that would be contraindicated to use one of those. But we may or may not look at these airways later. So let them seize. If they're in status, then you start bagging them. Get them some oxygen, breathe for them. It's a life-threatening event. Otherwise, what will happen is the patient will seize, okay, to go into this postictal state. So I would have, oh geez, lectures are killing me. I would have this little seizure. I would go into this postictal state, wake up. Nobody would be in class because everybody's like, seizure, let's get out of here. I'd wake up and go, where's everybody? Oh well. And then lay down and recover from my seizure, right? Okay. Or somebody could be nice and put a little oxygen on me and help me, right? I'd go get up, go change, and then go about my day. Most people who have these seizures, okay, out in public, they don't even transport. They just say, yeah, I had a seizure, I'll go get my labs checked, okay? I've got someone that can drive me home. No problem. So it's not a huge event unless it goes into that status epilepticus thing, okay? That's a problem. That's a life-threatening problem. Otherwise, just let them seize, and it's no really big thing. Any questions on generalized seizures? Now, later, much later, after you leave here, you'll learn more about seizures. There's a lot more to be said. The treatment for seizures, tonic-clonic type seizures, is benzodiazepine. Let's just say benzo. I don't know how to spell diazepine. D-I-A-Z-A-Z-P-I-N-E something. Or benzodiazepine, which a Valium fits into that. Everybody's heard of Valium, right? A Valium is a benzodiazepine. Versed is a benzodiazepine. Ativan is a benzodiazepine. I'm telling you these different drugs in case you see them or hear about them in the hospital. They're going to give them some kind of benzodiazepine, usually a Valium or Ativan. Now that stops the seizure outside of what we look at, the shaking. So you give them the Valium, and typically they're going to stop doing the tonic-clonic action. But they could still be seizing on the inside. We just don't see it. Now, how do you know that they're still seizing on the inside? This would be sort of a bonus question. You have to think about this.
Can they respond to it like on the command?
They could be still postictal. So, they've stopped shaking, but you think they're still seizing internally because those neurons are still firing. The benzodiazepine just stops the shaking. All right?
So you asked if they can talk to you?
No,
No, they could still be postictal. It's a sign.
diaphragm.
Now let me tell you something. Heart rate. If their heart rate is still up after you give them the benzodiazepine, more than likely they're still seizing. Okay? Not that you have to give them more, but that's just an indication that they still haven't stopped seizing, that their brain's still trying to get all these neurons together. So we let them seize, we provide them oxygen. What they're going to do in the hospital, they'll start an IV, they'll give them a benzodiazepine, they'll draw some labs, look at the different lab values that goes along with someone with a history of seizures, usually a dilantin level. They say, I want to get my levels checked. That means they'll draw blood work and look at their different levels, see if they need to adjust their medicine. Maybe they forgot to take their medicine, something like that, okay? So you look at that sort of situation. And then they may they'll be discharged and go along their way. All right. Now, here's the other thing. People without a history of seizures. I've never had a seizure, okay? But any of us at any time could have a seizure. Video games, cartoons, they all sort of been linked to people having seizures or people who have a history of seizures, little kids, that causes them to have a seizure because of the flashing lights. Okay? So if I went over here to the light, we'd see real quick who would have a seizure. Because this could, right here, this could invoke a seizure. If I do this long enough, it's going to make you nauseated. Flicking.
I'm already feeling
Okay? So, we could have, wouldn't that be something? I'll send somebody, like, cool, class. So so you have that, no history of seizures because these neurons are firing and something takes place and they start to disorganize. That is a major event in someone's life. If they have a true seizure and they don't have a history of seizures, that's a big event. They need to go to the hospital, they need to see a neurologist, they need to see why they had that seizure. Okay? Now, it is different than someone that gets up too quick. Like you're sitting down and you spring up right quick and you get all, everybody's done that. You get all sort of, start seeing the spots and everything and suddenly you go back down to the ground. That's something different. That's called orthostatic hypotension. Your blood pressure drops too quick, and you may twitch here and there, but you're not really having a seizure. All right. The other thing is trauma. Someone involved in a traumatic event, a wreck, a fall, something, a hit to a head, blunt force to the head, something like that. If you have a seizure related to trauma, it is a huge event. So these people need to go to a level 1 trauma center or a hospital that has neurological services. So if you've never had a seizure or you have a seizure related to trauma, then you need to go to a place that has neurological intervention, like a level 1, like a Baylor or a Parkland. Presbyterian or something word like that, okay? Everybody good on generalized tonic-clonic seizures? Any questions? There's a lot of people have seizures here in school. Don't hit the panic button. And don't let the teacher hit the panic button either.
We would like to watch.
Yeah, we'd like to have class. All right, last seizure, we're talking about petit mal or simple seizures or partial seizures, okay? These things have a number of different things that take place. One of them, they could sit there and just shake their hands, almost like a Parkinson type thing, right? They have one hand like this, or like a little tick, you know, where they're just doing this. These seizures can last hours and hours, okay? They're able to respond to you. They're in these petit mal seizures. Usually they don't require intervention because they try to take care of them themselves. The only ones I've ever been associated with is you go out there, guy has a long-standing history of these petit mals. He's been trying himself for 8 hours to get it to stop, and he can't get it to stop. So he needs some drugs. He needs some different drugs than what he's been taking. All right? So that's the case there. Back in the day, these seizures, when they finally figured out, one thing about them is that you can have this sort of this one handshaking or a little tick or something. Y'all know what I mean by a tick, right? Just sort of a twitch or something, right? Back before then, they used to, in elementary school, these teachers feel bad now because what would happen is the little kids would sit there and the teacher would be teaching and the kid would just sort of stare off into space like this, and they'd just go, and then minutes later just pick right back up where they left off. Now back then, what they do, the teacher would come along with their ruler and hit you, right?
Yeah.
Wake up, pay attention. And the kid would just... So once the kid sort of recovered from that, and the teacher would snatch them up, take them to the office, or whatever. Actually back then, they just take them out in the hall, find their board, and give them a swat, and tell them to quit, you know, pay attention in class. Or the bigger ones would swat you in class. That was always fun. But so they would do that, but they found out what these kids were having were petit mal seizures. The child could just be, or adult, they sort of just look and sort of gaze. And then, in an undetermined amount of time, they come out of it. But what's really spooky is when they come out of that, they pick up their conversation where they left off. And we've seen them for 15 or 20 minutes, where you sort of walk the person over to the chair, set them in the chair, right? And they're just having this seizure, this petit mal seizure, and when they wake up, they start talking about the same thing they were talking about 15 minutes ago. And life has passed them by. They don't remember any of it. Now, one thing that you think that you could do or not do would be what? You have petit mal seizures where you sort of gaze off like this. What's one event in life that you shouldn't be doing? Who said driving? Driving. There's some major accidents happen when people have a seizure while they're driving. They're driving illegally. Once you have a seizure, your license is revoked until you do not have a seizure for 6 months. I believe that's the time frame. So if you have a seizure, you go to a hospital, that's reported, you're supposed to turn in your license for a period of 6 months. 6 months seizure free. If not, you had this horrific accident. Can you imagine driving down the road at 70 miles an hour once and you go? It's not necessarily you, and I've had this conversation with an elderly person before. I said, it's not necessarily you, it's the person that you're going to hit. Driving 70 miles an hour, you're going to kill somebody.
If not themselves.
Yeah, you're probably yourself and them, because you won't obey the law and not drive. You can't drive. It's very dangerous to drive with a history of seizure. A friend of mine was a paramedic, and he had a seizure in the back of the ambulance. He ended up in the wheel well of the door of the ambulance. He seized. partner opened the door and he was laying over by the door. Well, post-ictal, right? It's like, okay. You know. Got a different job. Can't transport patients if you have a history of seizures. Okay? So till you get it under control, you get your medicine under control, right? And you're able to adapt like that. But these petit mals, you probably won't see too many. You may see a few in the hospital here and there. And these things last for hours. They can respond to you. They just need something to help them stop. No one fakes that for 8 hours to get medicine. You know, these guys are in the non-faking category, really. Questions? All right. So, other causes: drugs, alcohol, big time alcohol. Alcohol, get into an alcohol toxicity thing, you can start seizing. Drugs, illegal drugs. Usually when meth heads start seizing, that's their point of walking towards the light. When a druggie starts to seize, it's life-threatening. It's on the brink of death. Okay? People can seize taking drugs for the first time. Take a drug, take an illegal drug, have a seizure, you're still on the brink of death. It's still life-threatening for you. Okay? Come up with a tumor, that. Infections or high fever. You get a real super high fever, can have a seizure from that. Kiddos have them all the time, febrile seizures. It's not really that bad a thing with a kiddo. An adult, it is. Diabetic seizure for low blood sugar. Trauma, we talked about that. That's a big thing. Have some sort of stroke, hemorrhagic or ischemic stroke. Remember those two? Okay. Heat stroke. This is an environmental, it's like outside type heat stroke, not a medical heat stroke. The heat stroke's defined as when the body temperature gets above 105 degrees. So no, not in the heat stroke. No, we burn it up. You're thinking of fever. Epilepsy, that's the most common. And then a lot of unknown cases. A lot of neurologists were saying, well, we just don't know why they're seizing it. We don't give them medicine for it and control it. We just don't know what's causing it. This is where they do the EEG. They put all the things on the encephalogram, something, right? They put all the things on and they monitor your brain waves and look at that. So quite a bit of causes for the seizures when we take a look sort of at the whole picture. So they don't stiffen up. They don't have the decorticate or cerebral posturing, sort of a drawing in or extension out. Apnea. What's apnea?
No breathing.
No breathing. Incontinence, we talked about that. Usually the bladder, the convulsion type things, they go in this postictal state, a lot of altered level of consciousness. So we'd want to make sure that, like we talked about, make sure their airway's clear. We don't hold them down. We put them in a recovery position after their seizures, so roll them over their side in case they start to vomit. And provide oxygen if available. I think the only reason you protect their privacy is in case they, urinate on themselves. I don't know of any other reason. Questions there? Any questions on seizures?